Thank you, Navindu. Thank you very much.
The President-elect of UP State Ophthalmic Society. I welcome our President, Dr. Manoj Chaturvedi, sir. So please come on stage.
बॉस का आशीर्वाद मिला बिना शुरू हो नहीं सकता था.
सर गुस्ताखी कर ली हम लोगों ने सबको वेलकम कर लिया आपके आने से पहले. So Abhijat, be ready as the second speaker.
Yeah. Good afternoon, everyone. Thank you, APO and UP Ophthalmic Society for giving me this opportunity. I will be discussing about the recent trends in toric IOL. Cataract surgery has now become a refractive surgery. Patients' expectations, as you all know, are increasing day by day, and they want minimal dependence on glasses. Uncorrected vision gives rise to poor quality of vision, image distortion, and more than 1/3 of the patient have more than one diopter of astigmatism. The sources of astigmatism are anterior surface of the cornea, posterior surface of the cornea, and the lenticular astigmatism. Doctors are still hesitating in putting toric IOL because they feel that come at an extra cost, and secondly, the phobia of rotational stability. But the rotational stability is not an issue anymore. The IOL quality is very good. Technis has a frosted design, Alcon has a sticky surface, and obviously Indian lenses are also very good. Toric IOL need no extra skill. This should be considered in patients with astigmatism. Regular astigmatism can be easily corrected with toric IOL. It is better to avoid in irregular astigmatism. Recently, we also start considering posterior corneal astigmatism in measurements, and PCA is included in many recent biometer as a total K or TK. Importance of accurate biometry definitely is must to rule out any prior eye drop, any touch procedure, any surface abnormality. What should be the ideal thing to measure keratometry and the axial length? Obviously, the ideal thing is pentacam, and axial length is optical biometer. But in my view, if you don't have access to these equipments, you can very well do toric IOLs, because manual K and immersion gives equally good results. Before start, Dr. N.K. Singh sir, please. आपके बिना कैसे होगा? Before starting toric IOL, one must know his SIA. Many online calculators are available. Alcon Barrett, which gives printout like these. As we see the 3 degree almost adjacent to the incision, so we can mark at 3 degree and definitely incision will be almost around that. Hoya calculator, you can give your data to any company. They will provide a sheet, Care Group and ASCRS Barrett Toric calculator. Pre-operative marking is the most important step. One can do it on slit lamp or a bubble marker. I prefer to do it on slit lamp, and I don't mark 90 degree or 180. I directly mark the axis of the IOL, so that intra-op marking is not necessary anymore. If you have Varion and other Galsto devices, then there is no need to mark, obviously. Always make sure marking is when the corneal surface is dry, and don't use too much ink. A gross alignment is must. You must have to keep a printout of the sheet of the toric IOL in the OT. OVD removal under the IOL is must, and it is not a very difficult step. But the only thing you have to take care of is when you remove the OVD behind the IOL, try not to dislodge the IOL up and down and right and forth. Don't rotate counterclockwise. Try to keep IOL at least 20 degree around before that toric mark during OVD removal. Then you align it with the mark and then hydro procedure. Post-operatively, if the vision is 6/6 or 6/9, there is no need to check or tell patient. But if you feel that the vision is like 6/12, 6/18, then you must dilate, check the alignment, because rotation on day 1, 2, 3 is easier than it could be later on. How much to rotate and how to rotate? We have a site called astigmatisfix.com. We can put that data, and that will solve the purpose. If you are using for a premium lenses like trifocal and EDOF, then your threshold for toric lens uses should be low. I think it should not be more than 0.5. What are the tips for successful outcome? Basically, biometry accuracy is good. Single technician or maximum two, which is well versed. Discontinue any contact lens, obviously any ocular pathology, dry eye, etc. Good pupillary dilation is the must. Incision on the plant axis, CCC is very important. If you have a small CCC, then the chances of rotation of the IOL is very less. And obviously, you have to remove the viscoelastic, or you can do a hydroimplantation. Loss of correction with rotation can happen. 1 degree rotation can loss of astigmatic power around 3.3%. With good pre-op assessment, accurate biometry, and meticulous planning, optimum results can be very easy to achieve. Any surgeon who can do phaco can do toric IOL. Thank you very much. Any questions? No, why?